non-neoplastic salivary gland diseases. These are basically inflammatory enlargements of salivary glands. Sometimes there is just enlargement of either the major salivary glands, that is the parotid, submandibular or submaxillary glands, without any obvious neoplasm or underlying tumors. So all those diseases come under this non-neoplastic salivary gland diseases. Basically, they are tumor-like lesions. Okay. Sialadenosis. Sialadenosis is a non-neoplastic and even a non-inflammatory enlargement of the salivary glands. Basically, here what happens is, if it is involving the parotid glands, it shows the bilateral enlargement of salivary glands along with pain. And the enlargement may be recurring in nature. It may be present for a few days, it may regress, and again it may be appearing. And clinically, when you see the lesion, it appears to be of afebrile enlargement of the salivary gland, which is chronic in nature, and the lesion, it appears to be a slow growing one, slowly evolving, undulating in nature, and recurrent in nature. And it's sialadenosis. The etiology behind it is unknown. Sialadenosis, most commonly this characteristic salivary gland enlargement, it is being associated with associated other systemic syndromes or systemic factors, systemic disorders. Okay. So here in sialadenosis, there is enlargement of the parotid glands, enlargement of the underlying salivary gland enlargement along with pain. And this sialadenosis is basically seen in older aged individuals, that is above 4 decade or 40 years of life. And clinically, along with enlargement, you see that appearance of xerostomia, that is the salivary secretion is decreased. And when you take a sialogram of such an individual, you see that there is characteristic appearance of leafless tree on a sialogram. That is, the hypertrophy of acinar cell leads to compression of acinar cells on the terminal ducts, leading to the characteristic appearance of the leafless tree pattern. So when you see the microscopic picture also, there is predominance of acinar cells. The acinar cells hypertrophy is seen. How the acinar cells appear. The acinar cells, they basically appear to be very large in number and size. The nuclei is just pushed off to one side, and the cytoplasm is just densely packed with eosinophilic granules. Inflammatory cells may be absent, but what happens is the acinar cells predominate, and few adipocytes or fat cells are seen scattered here and there. The treatment for this is, I told you that sialadenosis is associated with a systemic disorder. So whatever systemic disorder is accompanying this enlargement, if you treat the systemic disorder, automatically the symptoms of this enlargement will resolve. Necrotizing sialometaplasia. Necrotizing sialometaplasia, it's also known as a salivary gland infection. It's basically a non-neoplastic inflammatory condition of the salivary gland. Basically, the etiology for occurrence of this necrotizing, that is the necrosis of the salivary glands, is seen. The etiology for occurrence of this necrosis is unknown in most instances. Sometimes it has been attributed to episodes of trauma or a history of surgery, previous surgery, or history of radiation therapy to that area, denoting that the immune system is decreased there. Basically, it affects the minor oral salivary glands of the oral cavity. Here it presents as a painless swelling with or without ulceration, and the minor salivary glands, they show the appearance of both the mucus cells and the serous glandular tissue. And we know that minor salivary glands are basically concentrated in the palatal region. So palatal region shows the occurrence of an ulcer which is midline in region, which is crateriform. The ulcer, it's about 1 to 3 centimeter, and it's leading to erosion of the underlying palatal bone. So, and there is necrosis of the adjacent tissue. There is a severe discoloration of the tissue, severe blackening of the tissue is seen. When we see the microscopic picture of the tissue affected by this necrotizing sialometaplasia, you get to see that there is coagulative necrosis of the acini. Basically, the minor oral salivary glands are affected. So both the serous and the mucus cells are affected. There is a pooling of mucus, and there is presence of obvious inflammatory infiltrate, macrophages, neutrophils, leukocytes, and there is no treatment required for necrotizing sialometaplasia because it just resolves spontaneously and it regresses on its own, and but the healing time about 3 to 5 weeks is taken. You have to just maintain the oral cavity, hygiene has to be maintained to allow it to heal on its own. So necrotizing sialometaplasia, the clinical features, they stimulate of underlying malignant neoplasm. So basically, if we see the etiology also, this necrotizing sialometaplasia, it has been seen in tissues adjacent to the neoplasms, and it is this necrosis is actually arising because of ischemia of the glandular epithelium in the minor oral salivary glands. Adjacent neoplasm is there, and because of that there is vascular ischemia of the glandular epithelium leading to the underlying necrosis. So that is the reason it just resolves on its own. Just the thing is, it takes some healing time of about 3 to 5 weeks. Benign lymphoepithelial lesion. Benign lymphoepithelial lesion, it's also known as Mikulicz syndrome. It's basically the abnormal enlargement of both the salivary glands and the lacrimal glands. Parotid gland and the submaxillary glands, they are showing the characteristic enlargement of this. Previously, it was thought that the Mikulicz disease or the benign lymphoepithelial lesion, it is associated with other diseases, that is some form of tuberculosis or sarcoidosis. They are leading to this enlargement of this salivary and lacrimal glands. So that's the etiology behind that. So the author, Mikulicz, he proposed the occurrence of two terms, that is the Mikulicz disease when the etiology is not known. The etiology behind the occurrence of enlargement is not known. The Mikulicz syndrome term is used when the enlargement is associated with other diseases like the tuberculosis or the sarcoidosis. Okay, so how is the enlargement characteristically seen? Initially, the patient develops enlargement of the salivary gland and xerostomia. Later, there will be enlargement of the lacrimal glands is seen. Reduction in tears or photophobia is seen. And the swellings of salivary glands, they are painless, they are just bilateral. And this disease, basically etiologically, it was thought that the benign lymphoepithelial lesion is basically an autoimmune disorder, or sometimes it is associated or occurring because of other infectious diseases like the tuberculosis or the sarcoidosis. So, because of enlargement of salivary gland, there is reduction in salivary secretion, so xerostomia is obviously present. Because of enlargement of lacrimal gland, there is reduction in tears or reduction in lacrimal secretions is seen. And sometimes few of the individuals, they show occurrence of systemic symptoms like fever. This fever, whenever it's occurring, it's associated with dry eyes, dry mouth, and diminished lacrimation. And because of the extreme dryness of the eyes, it initially leads to occurrence of conjunctivitis, and later stages uveitis are seen. When you see the microscopic picture of the salivary gland tissue, basically this benign lymphoepithelial lesion, it occurs because of the glandular epithelium is just replaced by the lymphocyte. So extensive lymphocytic infiltration of the salivary gland tissue is seen. You should not confuse this lesion with the malignant lymphoma, because lymphoma is also one lesion where extensive salivary gland proliferation or the lymphocyte proliferation is seen within the salivary gland tissue, as in Burkitt's lymphoma or malignant lymphoma. You have to just differentiate between the benign lymphoepithelial lesion and the malignant lymphoepithelial lesion by the appearance of the characteristic epimyoepithelial islands, that is the occurrence of both the epithelial cells and the myoepithelial cells. So the salivary gland structure, the glandular structure of the saliva, that is the acinar cells, is completely destroyed by the infiltration of the lymphocyte. That is, the lymphocyte just replaced the total acinar cells. And the epithelium, it also shows changes in the ducts The ductal epithelial cells, they show loss of polarity and appearance of clumps of epithelial islands of cells here and there. That is nothing but the epiomyoepithelial islands. So the basis for distinction between the malignant lymphoma and the benign lymphoepithelial lesion is the occurrence of these epiomyoepithelial islands. And to diagnose this lesion, biopsy of any of the swollen, either the lacrimal gland or the salivary gland, more commonly salivary gland biopsy is taken to confirm the occurrence of the Mikulicz disease or the Mikulicz syndrome. Treatment, there is no particular treatment for this disease except for symptomatic treatment can be given. In case of xerostomia, artificial salivary substitutes can be given. In case of extreme dryness of eyes or occurrence of conjunctivitis, artificial tears or lubricants can be given to maintain the moisture in the eyes and to maintain the saliva of the oral cavity, because the occurrence of xerostomia itself brings a lot of other diseases or the caries or irritation or glossitis and a lot of other things. Sjogren syndrome. Sjogren syndrome, it's also known as Sitka syndrome. Basically, Sjogren syndrome, it was described by an author in 1923. His name was Sjogren, so the name Sjogren syndrome. It was basically Sjogren syndrome consists of a triad of keratoconjunctivitis, Sitka, the xerostomia and the rheumatoid arthritis. So occurrence of these three diseases or symptoms simultaneously, they are grouped under the term Sjogren syndrome. And there are two forms basically. The primary Sjogren syndrome, it's also known as the Sitka complex. It's the one which is not associated with any other autoimmune disorder like the rheumatoid arthritis. Okay, basically this primary Sjogren syndrome it shows the occurrence of the keratoconjunctivitis, Sitka and the xerostomia. There is the dry mouth and dry eyes only. Whereas the secondary Sjogren syndrome, it is associated with other underlying systemic or autoimmune disorders. Okay, dry eyes, dry mouth and any systemic disorder can be seen. Etiology is basically genetic etiology, maybe some mutations in the gene giving rise to this disease, some autoimmune disorder or some infectious disorder which is affecting the individual leading to occurrence of this dry mouth and dry eyes. So basically Sjogren syndrome is seen in females more commonly above 40 years of age. So as I told you, the characteristic symptoms are the dry mouth because of enlargement of the salivary gland. Here in the clinical picture you can see that the parotid gland is showing enlargement. That's why this lesion is called as a tumor-like lesion, because when you see clinically you just cannot make out if it is a neoplasm or if it is a just infectious disease. So based on histological diagnosis on xylogram, you can just clearly make out. So Sjogren syndrome clinical picture, there is enlargement of the salivary gland. Along with that, there is occurrence of xerostomia. So there is dryness of mouth, and when it's involving the lacrimal gland, there is decreased secretion of lacrimal glands leading to dryness of eyes. So because of dryness of mouth, it leads to painful and burning sensation of the oral mucosa because of decreased salivary secretion. Saliva helps to maintain the moisture in the oral cavity. To maintain the epithelial integrity, saliva is essential because it has a lot of anti-nuclear factors and whatnot. So when the secretion is reduced, the tongue also shows the occurrence of inflammation. There is atrophy of papillae, there is occurrence of glossitis. And association of other systemic disorders, the characteristic manifestations of that particular systemic disorders may also be seen. And along with the decrease in secretion of oral cavity and eyes, sometimes we also see that the decreased secretion of the nose, the pharynx and even the vagina also shows extreme dryness. So parotid gland enlargement, along with that regional lymph nodes are enlarged, lymphadenopathy is present, and any other systemic disorder associated, most commonly rheumatoid arthritis association is present, so that's seen. So these are the clinical features. When we see the histologic picture or the microscopic picture of a person affected with Sjogren syndrome, there are three different patterns of microscopic picture of the salivary glandular tissue. In the first type, there is, as I told you, there is extensive lymphocytic infiltration. So the predominance of lymphocytes occur there, which replace all the acinar cells. but only the lobular structure is present. The acinus is basically a lobe-like structure with occurrence of acinar cells. So the acinar cells are just replaced by this fat lymphocytes, but the integrity of the structure is maintained. That is a acinar lobular structure. The salivary gland basically it's lobular structure. So that lobular structure is preserved, but the underlying acinar cells are replaced by the lymphocytes. And in other type, there is proliferation of the epithelial cells and the myoepithelial cells, leading to formation of the characteristic epio-myoepithelial islands. In other type, there will be simple atrophy of the epithelium, and lymphocytic infiltration is obviously present. So simple atrophy of the epithelium along with lymphocytic infiltration. So these three are the characteristic patterns seen in lymphocytic infiltration of this glandular salivary tissue. The characteristic laboratory cells which help in diagnosis are the anti-nuclear antibodies, that is the salivary anti-nuclear antibodies, anti-DNA antibodies, and globular cells are increased. That is the globulin deposition is increased. That is the hyperglobulinemia is seen, and in case of occurrence of secondary Sjogren syndrome, rheumatoid factor is also present in the blood in case of lab diagnosis. The sialogram, the appearance of sialogram is characteristic. So when silography is performed, if you can see the sialogram there, sialogram is basically taken by injecting a radio-opaque dye into the salivary gland tissue, and series of characteristic radiographs are taken. So it shows the occurrence of cavitary defects which are filled with radio-opaque contrast media. So basically the acinar structure is destroyed here, right? So whatever structure is destroyed is just replaced by that radio-opaque contrast material, which is seen as cavitary defects, and giving rise to the term cherry blossom or branchless fruit laden tree, because the ductal structures are completely destroyed. Only the acinar, that too, thus the lobular structure is preserved. So fruits are present, but the branches are absent, giving like that branchless fruit laden tree appearance. Treatment, there is no particular specific treatment for this Sjogren syndrome, because whenever in case of secondary Sjogren syndrome, you have to just treat this systemic disorder, rheumatoid arthritis, present by appropriate immunomodulatory drugs or immunosuppressive drugs, and along with that, so in case of dry mouth, xerostomia, you just give artificial sugar substitutes or salivary substitutes or sialogogues as they are called, and in case of to maintain the lubricant of the eye, to maintain the moisture content, ocular lubricants can be prescribed. So that's to overcome the keratoconjunctivitis. Okay, symptomatic treatment is basically given in the case of Sjogren syndrome. Now, those were the characteristic non-neoplastic tumor-like lesions. There are other cystic lesions occurring in the oral cavity or involving the salivary gland. Specifically, we have studied about the lymphoepithelial cyst. Lymphoepithelial cyst is nothing but the proliferation of the normal lymphoid tissue within the salivary glands. We have already studied about it in detail. Now we'll see the salivary duct cyst. Salivary duct cyst is nothing but a cyst occurring within the ductal tubular system. There is a ducts. The ducts are basically the striated duct, the intercalated duct, the terminal duct. These are the ductal. These comprise the ductal system of a salivary gland, right? So anywhere, along the duct, you can see there is proliferation of the epithelium leading to formation of a cyst-like structure. This cyst may be either acquired or congenital. How the cyst arises? Within the duct, it arises because of obstruction of the duct by presence of any foreign material or the proliferation of the epithelium. So when you see clinically, it presents as a painless swelling, which is just very small in size, very small in diameter, and there is no involvement of the facial nerve. There is no underlying fixation to the skin. Basically, the size of the tumor, size of this cyst is very small. So it may be soft to palpate also. The cyst may be only 0.8 to 10 centimeter in size, and it is more commonly seen in individuals above 40 years of age. Just because of obstruction to the duct, it arises. When you see the microscopic picture, obviously epithelial, the ducts or whatever ducts are present, they are lined by epithelium, right? So ductal epithelium is maintained or preserved. That is, the epithelium may be single layered or a multi-layered, cuboidal or columnar epithelium as seen in the particular duct. And because it's occurring in the salivary gland, occasional mucus secreting goblet cells are seen, and with a definite infiltration by the lymphocytes. Treatment for this is nothing but surgical resection of the cyst. So that's about the salivary duct cyst, which is arising just due to the obstruction of the duct, any duct. This chronic sclerosing Sialadenitis of submandibular gland, also known as Cutner's tumor, as the name indicates, Sialadenitis. That is, it's an inflammation of salivary gland tissue, basically known as a Cutler's tumor. It arising because of a bacterial infection. Bacterial infection may be because of any organisms. Oral cavity or has a lot of organisms, microorganisms inhabiting it. Any of the microorganism may be the causative factor leading to occurrence of this Sialadenitis. So there is inflammation. Obvious inflammation is present whenever bacteria enters the oral cavity. That leads to the enlargement of the salivary gland. It's basically a benign inflammatory condition, but because of the clinical symptoms, it may give the appearance of a malignant neoplasm. And clinically, this enlargement, it presents as a hard mass which is not fixed to the underlying tissue. So it is different from the neoplasms. So when you see the microscopic picture, microscopically it appears as the ductal structure is preserved. There is no damage to the acinar cells. Only there is thickening of the fibrosepta. The septa, the lobular septa, they become sclerotic. They become thickened. And obviously inflammation is present, so dense inflammatory infiltrate is present, and there is loss of the acinar structure because of replacement by this inflammatory cells. Okay, Sialadenitis, it's basically inflammation. Okay, Sialolithiasis. Sialolithiasis. Lithium is nothing but a stone. Sialolithiasis is the occurrence of stone within the salivary gland tissue. Most commonly, sialoliths are encountered in the ductal system. Basically, how the salivary ductal stone arises. It arises because of deposition of calcium salts around a nidus. This calcium, we have saliva also normally has a lot of calcium and phosphorus content. Inorganic content of saliva has about 50% of calcium and about 30 to 40% of phosphorus. So they occur in unison. But whenever there is some irritation or some nidus formation is there, it leads to deposition of that calcium salts at one place, leading to formation of a stone in the oral cavity. This deposition of calcium salts may occur within the ductal lumen, leading to just obstruction of the duct and enlargement of that particular tissue, which is very, very painful in nature. Clinically, how do you diagnose a ductis? Whenever the patient is given a meal, okay, whenever the patient is taking food, at that time he experiences severe pain, because whenever we are eating food, there is just excessive secretion of the saliva. Because of blockage of this ductal system, what happens is, though the saliva is secreted, the lumen of the duct is obstructed, so the secretion is just not able to enter the oral cavity or come out through the duct. It leads to pain in that region. So that's episodic pain or swelling of the affected gland may be seen. So when you see the duct or the sialoliths, they appear as calcified mass or stone, which are ovoid or cylindrical. On radiographs, they appear as radio-opaque masses. They may be yellowish, white or yellow in color. Here you can see the clinical picture. There is appearance of unilateral swelling. It's because of a sialolith involving the submandibular duct. Here, if you can see in the clinical picture, in the floor of the mouth, the arrow just points to a yellowish white color thing seen in the oral cavity. That is nothing but sialolith. You can just feel it when you palpate it. You can feel that there is a stone. You just with a gloved finger, you have to just palpate it both intraorally and extraorally. you can just feel the stone within the oral cavity. Okay, submandibular stones tend to be very, very large in color. As we know, there is a lot of secretion of saliva, and the submandibular gland duct is more active when we are just eating our food. So more sialoliths are encountered in the submandibular gland. And radiographic examination, radiopaque masses are seen. When you see the microscopic picture, the calcified mass, it just shows that deposition of calcium salts around a nidus, or there is a deposition of calcium salts in layers, concentric layers like thing. And how do you treat this condition? If the ductal orifice is present, as in case of submandibular gland duct, the ductal orifice opens into the floor of the mouth, right? If you are able to weave the submandibular gland duct, and if just gently massage the gland or the duct, that's nothing but called as the milking of the gland. It leads to expulsion of the sialolith into the oral cavity. That is, just by gentle massage or milking of the gland, the sialolith may be removed. Sometimes if it is superficial, if it is like deeply situated, you have to just resect the duct. That is, the surgical removal of duct has to be carried out. This condition is extremely painful because it leads to inability to eat the food, and whenever the patient is making any attempt to eat the food, this condition just gets worsened. Sialadenitis, as I told you, sialadenitis is basically inflammation of the salivary gland occurring because of any underlying cause, like occurrence of previous surgery or bacterial infection may be the causative. In sialadenitis, you get to see that there is enlargement of any gland, either the major salivary gland, parotid gland, submaxillary gland, or the submandibular gland. So either the infectious cause, either the bacterial cause may be a causative, or irradiation of that area previously because of any surgery or tumor may be the causative factor. So acute bacterial sialadenitis, it is more commonly seen in the parotid gland, and there is bilateral enlargement of the parotid gland, and because of inflammation, the overlying skin, it's appear erythematous or pinkish in color. It is stretched and shiny, and there is enlargement of the salivary gland, right? So the affected gland is swollen, and it is extremely painful condition. And this sialadenitis, it is associated with occurrence of systemic symptoms like the low grade fever, pain in that particular area, pain in the muscles of mastication also, if it is involving the parotid gland, and that is trismus. And because of inflammation, as the inflammation progresses, the overlying skin is just stretched, and the erythema progresses. At one point, it just tends to discharge to the surface like a sinus tract is formed. That is acute bacterial sialadenitis. Chronic sialadenitis is occurrence of inflammatory enlargement of salivary glands over a large period of time, and it is very slow in onset, and it is characterized by periodic swelling of the salivary gland. Periodic swelling, and even the pain is also periodic. Usually this chronic sialadenitis, it develops at meal time only when the salivary flow is stimulated. So sialography, that is the demonstration of punctate demonstration of the salivary lobular structure and the ductal system of the salivary gland by injection of a radiopaque contrast media. It shows that the ducts are dilated. There is the sialactasia, the term. The ducts are dilated only proximally. Okay. The treatment for this infectious condition or the bacterial sialadenitis is antibiotic therapy. Obviously, bacteria is the cause, so antibiotic therapy has to be given. Along with that, the patient is extremely weak, is suffering from fever, so you have to maintain the hydration of the patient, and you have to treat the systemic symptoms also. Sialorrhea. Sialorrhea, it is a condition which is characterized by excess salivary flow. So the patient just shows drooling of saliva characteristically. Few of the patients. More commonly in children with Down syndrome, you see that the patients are mentally retarded. They just don't have the control over their body. But so in such individuals affected with Down syndrome, we see the characteristic drooling of saliva. Even in patients who are suffering from recurrent aphthous ulcer. The commonest symptom which everybody or almost every individual suffers from, that recurrent aphthous stomatitis. In such cases, because of irritation, there is excessive salivary secretion. So etiology for Sialorrhea may be a recurrent aphthous stomatitis or an ill-fitting denture. Whenever there is a denture is like a foreign material placed in the mouth, right? So because of when the denture is not fitting properly, or it is a newly inserted denture, the patients tend to have excess salivary secretions. And because of heavy metal poisoning, as seen in cases of arsenic or mercury poisoning, more commonly it's seen in infants or children below 5 years of age, there is excessive salivation and there is metallic taste in the mouth. And few of the medications like the cholinergic medication, that is which stimulate the supply to the salivary glands. As we know, salivary glands are supplied by the parasympathetic nerve supply. So cholinergic medications are drugs which stimulate the parasympathetic nerve supply, and they just stimulate the salivary glands, leading to excessive secretion. So because of this excessive secretion, what happens is, whenever the individual is sleeping in night and by the time he gets up in morning, he just notices that the saliva is drooling from his mouth. And in older individuals also, in individuals affected with Parkinsonism especially, the cholinergic drugs are prescribed. So in that cases, you see the drooling of saliva. And even when the patient sleeps and gets up, he sees that his bed and his clothes may be soiled because of the extreme drooling of saliva. It's basically an emotional problem for the individual to go out, because the saliva secretion is not under his control. Okay, it's just an autonomic nervous system involvement is there, and just constant drooling of saliva is very emotionally disturbing. So treatment for this is nothing but anticholinergic medication. Anticholinergic medication, it stimulates the autonomic nervous system and just it stops the excessive secretion of saliva. Xerostomia, anything deficient or excess is definitely harmful for us, whereas excessive salivary secretion is also harmful because it's causing emotional disturbance to us. Whereas reduced or defective secretion of saliva is equally dangerous, because whenever the oral cavity it shows reduction in salivary secretion, what happens is, saliva basically it's a thermostat. It maintains the temperature of oral cavity. It has many anti-nuclear factors and antibodies, so it protects the oral cavity from foreign body or any bacterial infections. And it constantly baths all of the teeth, so it just maintains the health of the teeth also. No periodontal, no carious infections are seen. So when the salivary secretion is reduced, lot of important functions are lost, and the individual or the teeth or oral cavity are just subjected to variety of infections. So why xerostomia or the decreased salivary secretion is seen? It may be developmental disorder because of reduction in the lobular structure or reduction in the acinar cells. That is nothing but salivary gland aplasia. Sometimes salivary gland itself is absent or reduced. So reduced salivary gland is completely absent. Aplasia, that in that cases there is reduced salivary secretion. Or sometimes there is water loss from the body, as in cases of chronic vomiting or nausea, anorexia, or the individual is anorexic. In case of chronic vomiting, there is excessive fluid loss from the body, so saliva is lost. In case of impaired fluid intake, when the individual doesn't take water in the required quantity, that also he shows this reduced salivary secretion. And in cases of medication, whenever anticholinergic medication are used to treat certain disorders also, you get to see there is dryness of the oral cavity. Radiation therapy for any benign or malignant tumors may also lead to dryness of the oral cavity. This dryness, it ultimately predisposes to inflammation or of the oral cavity. Systemic diseases like Sjogren syndrome or diabetes mellitus or HIV affected individuals all show reduction in salivary condition. And local factors like the occurrence of smoking. The individuals who smoke, they also show the reduction in salivary secretion. And mouth breathing individuals, sometimes there is any deviated nasal septum or any tonsillitis. The patient tends to just breathe from mouth rather than nose. So when the mouth is constantly kept open for a long period of time, it just leads to reduction in the salivary secretion. So whenever the salivary secretion is reduced, normally the saliva tends to be very thin and just mucus in nature, but here is the saliva becomes thick and ropey in nature. It just tends to stick. And the mucosa appears dry, there is inflammation, there is burning sensation of oral mucosa, the tongue appears dry, there is appearance of fissures on the surface of tongue, and there is loss of filiform papillae, there is obvious difficulty in mastication and swallowing, and there is increased prevalence of candidiasis and increased prevalence of caries. Treatment for xerostomia is nothing but induction of or introduction of artificial salivary substitutes, or the sugar substitutes has to be given. The xylitol gum can be given, or the sugarless candy, that is nothing but the xylitol, has to be given to the individual. Okay, so that's about the non-neoplastic salivary gland diseases.